Hello, it is Dr. Shelley with HETV and Shelley's Nursing Review, and we're going to talk about appendicitis today. So I want you to know that if you are following along with my NCLEX program, you know that the self-study has a packet for every single playlist. And if you understand my channel, HETV, all capital letters, HETV, you know that if you go to the playlist, you can find out where you need to be for every single subject. There's over 500 videos. It's all separated by subject and by playlist. So today we are in the GI playlist, right? Particularly, we are covering this page. If you go in just a little bit into the packet, it is going to be this page that we are covering. And I want you to see that. It comes after pancreatitis. This packet is acute GI. There's another one that says gastrointestinal, and that is chronic GI. So let's get started. Number one, I always think that a good review of anatomy is important. So we're going to talk a little bit about anatomy. And what I want you to know is the student that does the best on HESI, ATI, or NCLEX is a student who knows their anatomy. And I don't know about you, but I don't think I took anatomy and physiology that serious, but it is really, really serious. So here we go. Watch this. The way I get my students to know the GI system's anatomy is I use the mnemonic of GLASS, G-L-A-S-S. Now the problem is you have to start using this little symbol like I am facing you right now. So watch this. This line right here goes from my sternum all the way through the belly button down to the pubic bone. And then this line right here goes from one flank through the belly button to the other flank. So if you think about that, my right upper quadrant is right here. My left upper quadrant is right here. Y'all got me? So that's how you got to do it. You can't be like this and be like, oh, right side is over here. No, you have to turn around like this. And this is my right side, right side. Left side, left side. So let's do it. The first letter is G. So we're going to go ahead and take the G and put it in the right upper quadrant. That's the first letter. That's your gallbladder. So in your right upper quadrant is your gallbladder. Now get this, the G is followed by the L. Literally, just looking at these two letters, you could say the G is behind the L. Well, the L is your liver. Your liver is the right upper quadrant. The gallbladder is behind the liver. Okay, so that's your GL. Today's lecture is on the appendix. So that's your A. Your A is in the right lower quadrant. And you know you had to know that because when people act stupid about this, people die. Patients literally can die. And let me explain what I mean. It was break time in the classroom up in Cleveland. So if you've been up here for your 3-day boot camp, or if you've been in my class as a traditional student, you know that we have break time and it's about a 45-minute break time. Usually I make you watch Grey's Anatomy so you're learning something on your lunch break. Well, this particular day, I had a delightful student who I've known for a while, and she was kind of doubled over, not feeling good, moving kind of slow. And the way this works is at break time, you got to leave the classroom so I can actually have a lunch break as well. And she was kind of moving slow. And I said, what is the matter? She said, well, you know, they say I got fibroids. I was seen at the emergency room yesterday, and they told me that I had fibroids. I said, well, well, where is the pain? Because you remember, I was an OBGYN for 20 years, so the whole fibroids is right up my alley. And this woman is about 50 years old. And I'm thinking, well, she should have knew she had fibroids before 50. That's just in my mind. So I'm probing a little bit more. I said, well, baby, where is the pain at? Y'all ready for this? Oh, yeah. She pointed right here in her what? Right lower quadrant. I said, well, that sounds like appendicitis. She said, well, no, they said it wasn't appendicitis. They said I was too old for that. What? Okay, now let's keep it real. It is true that most appendicitis occurs between puberty and 30 years of age. That's true, but anyone can get appendicitis. So this was striking me as dumber than dumb for the hospital to even say that out loud. I said, well, what did they do? Well, they gave me an ultrasound and they looked around and they said that I got fibroids. I said, well, have you ever been told that you had fibroids before? She said, well, no. I said, and you're saying it hurts right down in the right lower quadrant? She said, yes. And they gave me some codeine. I thought, oh, that's horrible because codeine is constipating. And if you bear down with this horrifying emergency condition, you can burst your appendix. So I said, oh, no. I said, here's what I need you to do. I'm going to have you get driven right back up there to that Hillcrest Hospital up the street, 10 minutes away. I want you to go to that Hillcrest emergency room, go back and let them know what you're feeling. I think this is your appendix. Sure shit, she texts me a little while later. I'm having surgery for appendicitis. No shit, Sherlock. You almost lost your life. In my mind, I'm not telling her that, but I'm thinking she almost lost her life. This is life-threatening. Don't get it twisted. Your inability to figure out that right lower quadrant pain might be somebody's appendix can kill them. That's why we're going over this here glass. All right, you ready? I hope you're ready. I hope you're listening. Hell. GL. Now we got an A up in here. Now we have 2 more quadrants left, don't we? And what do we have left over? 2 more letters. Now I know y'all know that I got issues and sometimes I'm a little raw. Well, this is one of those times. You have an S and I would like you to write shit. Yeah, I said it. All right, fine. Some of y'all is just too professional for me. It ain't never been my problem. Clearly you were raised well, decent people. Not my issue. But so if you don't feel like writing shit and you're having a problem with that, go ahead and write sigmoid colon, because that's really what it is, okay? It's just sigmoid colon, full of shit. All right, now there's another S. There's another S. Let's go ahead on and put what that S is. You should have figured it out by now. This is actually your stomach, but also to a lesser extent, your spleen. Let me explain. Your stomach is over here in the left upper quadrant, but your spleen is also in the left upper quadrant, a little bit below. Here's what I need you to know, reason why we're not really focused on the spleen right now. This is your GI organs. The spleen technically is not a GI organ. It's in the GI cavity, but it's not a GI organ. It's a lymphatic organ, really meant towards keeping you infection-free. I always say it's the vacuum cleaner for the bloodstream, and it's the garbage can for dead red blood cells. But we're talking GI today. And GI is GLASS, and you should now have all of your organs in place, and we can really dive deep into appendicitis. Now, once again, we said appendicitis is usually seen between puberty and 30 years of age. It can be any time, though. Don't let that lock you into getting somebody dead because you didn't think they could have appendicitis, like that woman that left up out of here and had to have her appendix taken out a few hours after leaving here. I want you to remember it's kind of common. 1 in 20 people have appendicitis. Y'all see that? 1 in 20 will have appendicitis. Now, your first nursing action, meaning they're going to show up in your ER. What do you do first? And don't get it twisted. New grads are hired right in the ER. I often get those new grads the job right in the ER at the Cleveland Clinic. So new grads can be in the ER. So you better like get it together, okay? Now your first nursing action is complicated because what I tell you is when you're trying to learn how to pass your NCLEX, HESI, or ATI, I tell you to remember systems. It's not a neuro system. It's not a respiratory system. It's not the endocrine system. It's not any of those systems. It's the GI system. And I teach you that this being a GI emergency, you've got a Jay-Z rhyme to remind you of what to do with these patients. Yeah, like now. But there is something that is even higher on the list of all of that. That would be to make sure the patient stays up more like a semi-Fowler's, high Fowler's with their knees to their chest. They'll be more comfortable that way. And what I mean by that is we know that if this organ ruptures, it's going to drain a lot of nasty, dirty, disgusting E. coli filled fluid. And you don't want that fluid to go up and infect all of this. You'd rather keep it draining down. So for this patient, we keep them in a semi-Fowler, high Fowler's position with their knees to their chest. Now, for all GI emergencies, just so you know your stuff when it comes to GI, we have that Jay-Z rhyme. Here's the Jay-Z rhyme. IVNG, Foley, type and screen, surgery, antibiotics, and electrolyte replacement. Y'all want to hear that again? I know you did. IV. So what is that? IV fluids, right? This patient ain't gonna be eating nothing. So you need to keep them going because they're at risk for dehydrating, low blood pressure with sepsis. Keep the fluids going. IV. Okay. The next one is NG, because if your patient is violently vomiting, this one is not necessarily, but if they're violently vomiting, they're going to need an NG for decompression. It's called gastric decompression. Now this one may not need an NG. In fact, I would wager they won't. But every time you hear me say NG, you think if they don't need an NG, then they damn sure need to be NPO. Choose one or the other, okay? Obviously, if you chose the NG, they're automatically NPO, but the NG might be overkill, and it would be for this patient. So IVNG, which is really NPO for this one, okay? Then we have Foley. The GI department and the GU department are very close, so if we need to do surgery in that area, your doctor might order a catheter, a Foley catheter, and we used to call them Foleys. A urinary catheter to continuous drainage means keep the bladder empty while I'm all up in here surgically operating. Don't let it be in my way, okay? Now, type and screen. Anytime you're gonna have surgery, you have to get a type and screen because in surgery, you could have tremendous amount of blood loss and need blood transfusion afterwards. So just in case, we need a type and screen. Then surgery, because most of these GI emergencies require surgery, and then antibiotics and electrolyte replacement. In the GI system is a ton of electrolyte loss if you have a problem, especially potassium. Okay, so that's kind of important. Antibiotics, oh, you know what I'm about to say about these antibiotics. And I'm just gonna say it. I hope you over there in your living room saying it with me. All GI is dirty. Yes, hunty. In other words, if you have a GI emergency, all GI is dirty. Liver's dirty. Pancreas is dirty. Your intestines are dirty. Your large colon is dirty. I mean, your large intestine, which is your colon, is dirty. Your gallbladder is dirty. Your appendix is dirty. Anything in this area of your body is dirty because of E. coli. So if all GI is dirty, there's a potential for all GI to end up with sepsis, which means your behind needs some antibiotics when you come all up in my house with your GI emergency. All right. Now, we're moving right along. Y'all doing good. Signs and symptoms. Well, there's a mnemonic. Now, I can't lie. I did not think of this shit. Sometimes I think of shit. I didn't think of this shit. I didn't think of glass. I didn't think of this mnemonic either. But I like the mnemonic, and I don't like a lot of mnemonics because a lot of them mnemonics is confusing, y'all. Y'all get all your mnemonics all confused. But I like this one. It's kind of simple. I can kind of rock with it, roll with it. Hopefully you can too. The mnemonic for the signs and symptoms of appendicitis is GRADE, okay? GRADE. You see it here, G-R-A-D-E. The first G stands for guarding. Your patient is going to guard that area. They don't want nobody touching it. They don't want it to hurt anymore. And so the patient will usually just instinctively curl up in a knee chest position. Sometimes they'll be on all fours. Sometimes they'll be in a fetal position. I remember the one young lady, because I often will ask the students in the class to describe their appendicitis because everybody's had one. In every single class, I average about 2 or 3 that have had appendicitis. And I'll ask them to describe what did they feel that day. The one girl was classic. She said, well, I noticed if I balled up, I felt okay. Like I could even try to get to sleep. But then somewhere around 4 or 5 in the morning, I had to use the bathroom. So I had to get out of my little balled up position. And I went like this to get out of bed and fell to my knees. And thank God my phone was with me because I had to call 911. I couldn't even move. That makes sense because here's what happened. When she was balled up, she put pressure on the area. It didn't feel so bad. But when she took that leg and those knees away from that to get out of that bed, she screamed. So I want you to remember guarding. The next thing I want you to see here for the R is what I told you earlier, right lower quadrant, but also rebound tenderness. Now this goes with the other part of guarding. Listen to what I'm saying. Rebound tenderness, pretend like I'm the provider and I come along and I want to see if there's any rebound tenderness. I come by, I stand by your side and I push down with my hand. I palpate down with my hand in that area and I say, okay, when I take my hand off, I want you to tell me what you felt. When I take my hand off, they're screaming. Ow! Okay, what happened? Same thing when the girl took the knee off. That's rebound tenderness. It doesn't hurt when I press it. It didn't hurt with her knee, did it? It actually felt better. But when I took my hand off of it, oh my God, it was excruciating pain. That's positive rebound tenderness. RR, okay? The A part of grade, we've done the G, which was guarding. The R was right lower quadrant, pain and rebound tenderness. Now the A is for anorexia, and sometimes students get confused. I know I did. Sometimes students get confused. Not anorexia nervosa. That's a psychiatric condition. You are terrified of being fat. You won't eat anything. You wear big clothes. No. The word anorexia just by itself, no other words with it. Anorexia just means loss of appetite. Okay, guys? So this patient is not in the mood to eat anything. They probably haven't eaten all day. And these symptoms are going on. They start kind of dull, but they're going on for hours, okay, before things get really bad. So anorexia, nausea, vomiting in some patients, not violent, but vomiting, okay, so you get it. Now the D in grade, the D I give you for dull, diffuse, which means can't really locate it or isolate it and go, it's right here. No, dull, diffuse, here we go, periumbilical, right? What we got? Periumbilical pain. Pain around the belly button. That's your belly button, right? Pain around that area. Initially, you're not necessarily in the right lower quadrant. You might or might not be, but for sure when the earliest symptoms were documented, or you thought when and how did this start, it was peri-umbilical. It was dull. It wasn't sharp. It wasn't, I need to go to the ER yet. That's how it starts. It's early. The E stands for elevated temp. Now, initially, this is a low-grade temp. Low-grade and high-grade, you got to know the difference. High-grade temperatures are 102 and above. Low-grade temperatures are below 102. This is going to start off as a low-grade temperature. So, elevated temp, then get this, elevated white blood count, elevated sedimentation rate, ESR, is going to be elevated. C-reactive protein may be elevated. Those are all like inflammatory markers. ESR and CRP, or C-reactive protein. These are all inflammatory markers. This appendix is inflamed, okay? Now, you got to watch out for one red flag symptom that should make you jump out your pantyhose and lose your damn mind. Here we go. If at any time your patient suddenly feels pain relief, their appendix just ruptured, scream for help, get them to the OR. That's what happened. Usually this is basically about 48 to 72 hours after the onset of that symptom of peri-umbilical pain, when it all got started. 48 to 72 hours later. This is why this is an emergency. You don't have much time. Okay, now, let me do some no-nos, because some of y'all be on some trash doing all kind of shit you ain't got no business doing on this test. No heating pad. I told your ass to leave the heating pads off people anyway. I said no heating pads on nobody, remember? I said quit burning your patients, okay? So no heating pad, no laxatives, no enemas, no cathartics, things that make you gotta go poop. None of that, because if this patient bears down, they're gonna rupture their appendix. So the thing is, all of these things can rupture the appendix. And the thing about it is, I tell you these and I really say them out loud because your patient, from time to time, comes in and thinks they're constipated. And you're like, oh, okay, well, when's the last time you went? And half the time, because the cause, are you ready for this? Are y'all with me? Stay with your girl now. You got to stay with me. Look at this, y'all. The cause is an obstruction. Cause is an obstruction or blockage due to hard stool or an infection of some sort. That's what caused the appendicitis in the first place, okay? And what is your appendix for anyway? Here's one for you. We don't know. When I get to heaven, this is praying that I go to heaven. Lord only knows. He ain't telling. But if and when I go to heaven, I'm going to say, God, excuse me, I know you're busy. I just got a question for you. What was the appendix for? Like, what was we supposed to be doing with the appendix? You know, because I'm a nurse and I'm just curious. All right, so this is blockage or obstruction due to stool or infection. We even say that prevention is kind of impossible, but we notice that we see less appendicitis in patients with a high fiber diet. Common sense tells you preventing constipation might be the key. So that's why I said don't get this patient no enemas and laxatives and nothing else, because they may come in thinking they're constipated and perhaps they haven't even gone in a while, and there you are thinking that's the problem, and it's not, okay? Now, so let's move on because we're almost done. This rebound tenderness, I meant to tell you, was at McBurney's point. That is just a certain point right there in the right lower quadrant, usually around the iliac crest, so around the hip bone. That's where McBurney's point is. That's where you press, and when you take your hands off, it hurts worse. I did want you to know the McBurney's point. All right, now let's go over here. How are we going to diagnose this patient? Well, to be honest with you, I've had several patients. One was pregnant with appendicitis, and the CAT scan was useful, but not really because she's pregnant and it didn't really declare anything. But a CAT scan is the #1 way we're going to try to figure it out, okay? Then we have a CBC, complete blood count. In the complete blood count, CBC with differential, we're looking at the white blood count. It's going to be elevated as hell because what I tell you, all GI is dirty. The ultrasound might be used as well to tell what is going on. Is it her gallbladder? Is the appendix? What's going on? To be real with you, the only 100% way to diagnose this is an exploratory laparotomy. We don't always have to go there, but sometimes we do. With my patient who was pregnant, we definitely had to go there. It's the only way to figure this out, okay? Now, complications of appendicitis. The reason why it's an oh my God, or who you see first, or medical emergency, or a GI emergency. The reason why the complications include ruptured appendix, and if it ruptures, there might be a ton of there will be a ton of infectious E. coli GI fluids that are now released into the peritoneal cavity, causing peritonitis. The way you're going to know it's peritonitis, the patient will have a rigid, board-like, distended abdomen and a very high fever, not low. This patient can get an abscess, and remember what an abscess is? It's a tumor of pus. Ew, my patient's appendix definitely ruptured. She was pregnant. It was that. It was green when we cut her open. Green, nasty green pus in there with the baby. Okay, so abscess, that's why I made it green, purulent pus, green. Okay. They can get sepsis because, again, all GI is dirty. Now you've got this dirty fluid in here with this patient. It's going all through her body and into her bloodstream. Oh my God. You already know what I'm about to say, because remember what I told you. I told you that sepsis kills more than cancer, strokes, and MIs all put together. So yeah, the real risk of appendicitis is death. Oh my God, it's death. There's nothing else I could say about that. How bad can it be? It can kill you. All right, now, let's look at what we're going to do about it. The treatment is surgery. We ain't going to be bullshitting you. The treatment is surgery. Now, 99 times out of 100, you need surgery to get the damn thing out. We don't even need our appendix. So what the fuck are we doing? Get it out of there. Surgery. The nurse knows, because all GI is dirty, we're going to be hanging antibiotics. We have a fever, so antipyretics. We might be vomiting, so antiemetics. And let me see what you know about your antiemetics. What is the generic name for Zofran? I can't hear you. Did you say it? I ain't heard shit. What did you say, honey? Come on out here, honey. Tell me what the daggone generic name for Zofran is. Did you say ondansetron? Yeah, the cetrons are antiemetics. Granesetron, ondansetron. I think that's what you said. Yeah, right. Okay, now, the patient with an abscess or a appendix that actually ruptured will need a Jackson-Pratt drain. And don't you forget that you got to empty that thing twice a day. You got to compress it for it to even suck anything out of the patient. It is going to be taken out when there's less than 25 cc's in the daggone drainage, Jackson-Pratt drain when you empty it, okay? So that's going to come out. Now, if the patient's appendix ruptured, they're going to need open surgery, right? A laparotomy, usually open surgery. A cut is made about 3 inches long, and they are going to need a 2-week recovery. They'll stay in your hospital overnight or so. They're also going to need a Jackson-Pratt drain. That's right here. If it's a laparoscopy, on the other hand, then they're going to go home that day or the next day with no problems, and they'll probably be able to resume normal activity in about 2 or 3 days. And so we know that this patient is young, and that is very appealing. And we know being able to get back to normal activities in a couple days is wonderful. So what is the take-home message? Diagnose early, guys. Let's all get together as a team, nurses, doctors, proceduralists. Let's get together and figure out appendicitis before it's too late, and we have to really, really pray that you make it through this emergency, this GI emergency. I hope that helped. Deuces. I'm out, y'all.